Okay, class, apparently my 15 minutes is 15 minutes, and so I just ran out of time to talk about pediatrics and sleep and the elderly and their sleep. So basically, just remember to think about babies. What do? They just eat, sleep, and pee, right? So pretty much that's what they're doing. Newborns sleep 16 to 17 hours a day. 53% of that time is spent in active REM sleep, and the infant sleep cycle is about 50 to 60 minutes. Infants will enter their REM sleep immediately upon falling asleep, which is nice. I wish I could do that. As we get older, though, it takes longer for us to fall asleep, and we are easily more awakened in the night. Amount of time in stage 4 sleep decreases, so can be caused by some physical ailments, some certain diseases, lack of daily routine. A lot of the elderly are not going to work, they're retired, so they don't get up, they don't have a routine of going to bed by a certain time and getting up. Their circadian rhythm changes, as well as medications. Some medications make it harder for us to fall asleep or actually makes us sleep more, so depending on what's going on. But most of the time as we get older, our sleep time is decreased. Did you see a pattern by chance with as we get older? Everything slows down, everything decreases. So that's kind of a clue with our elderly population. So let's talk about these eyes and what happens to our eyes. We have, of course, different alterations in our ocular movement. We can have strabismus, which is makes us look like we can see double vision, or diplopia. Nystagmus is dancing eyes, where there is a jerky pendular type of movement in the eyes when we are looking at the eyes. So YouTube videos are out there regarding these different visual dysfunctions if you want to preview them. We also have amblyopia, or lazy eye, and usually with lazy eye, one eye will deviate from the other eye, and they'll just patch the kid up or the adult with one over the stronger eye so that the lazy eye or the weaker eye gets stronger. Scotoma is diminished vision in the visual fields. We also we see patients with cataracts, which is just clouding of the eyes, and papilledema, where the optic disc is swelling, usually from increased intracranial pressure that we see. So we can also have, as we get older, we start developing dark adaptation, meaning we adapt to darkness but not as well when we are getting older. It's harder for us to drive at night. Retinal detachment can occur during certain damages to the eye, or even diseases such as diabetes. Age-related macular degeneration occurs as we get older. The patients start losing their eyesight and become legally blind. Glaucoma, there's different types of glaucoma, but basically glaucoma is the increased intraocular pressure that eventually all this leads to vision loss. So really the main one that we usually see is the open angle glaucoma, where the patients start losing their vision slowly. They start developing what they consider tunnel vision. Usually there's no pain, and the visual acuity slowly decreases. If it's not treated, they do not get their eye drops and things like that, blindness can occur with glaucoma. So 3 P's of blindness is, for the open angle, is preventable. The population should be out there educating to know to get their vision checked. If they see any problems in their vision, decrease in vision, actually, I should say, they need to come in and get their eyes taken a look at, because it is painless. They don't feel anything. It's not like they got a sudden pain and, oh, I got to go get it checked. It's painless, and unfortunately it is permanent, and so they are blind, and once they're blind, they're blind. So really sad. So we need to make sure they understand to get their visual eyes checked all the time. We could also have changes in accommodation, which accommodation is a process whereby the thickness of the lens changes. They have decreased flexibility in the lens. And so we might see some presbyopia, diplopia, blurred vision, and headaches. So our eyes are just not able to focus, and so we need to get this accommodation tested. There's also alterations in your refraction that you will see some people wearing glasses because they are myopia or nearsighted, meaning they can see near, or hyperopia, farsighted, where they can see far. A lot of times, patients might develop a stigmatism, which is blurred vision at any distance, and they can occur with myopia or hyperopia as well. Color blindness is an X-linked recessive trait, so that is why we see it in our men, because women have that extra X gene, so X chromosome, so we're okay, but men only have the one, so that's why they are more common developing blindness. Hemianopia is defective vision or blindness in half of the visual field. It is usually what we see after our stroke patients, and depending on, or head injury, depending on what has occurred. So if there's such example, if there's a lesion on the right optic nerve, you'll see right eye blindness. If there's a lesion in the optic chiasm, then they could be bitemporal hemangiopia, as well as then the left optic tract lesion can also cause the opposite bilateral right hemanopia. So again, those type of things can occur with head injuries or strokes. External eye disorders, you can see inflammation of the eyelids called blepharitis, or styes, infection in the sebaceous glands of the eyelids. You can have infections in the oil-secreting gland called chalazion, and keratitis, which is just infection of the cornea. Conjunctivitis is a common disorder we see with our kids. It's pink eye. It is highly contagious, so these kids need to stay at home. If you are taking care of anybody with pink eye, you need to make sure you wear personal protective equipment so you do not develop it. There is two different types. You can get viral conjunctivitis as well, or allergic conjunctivitis. So as we get older, we're going to have changes in our cornea, lenses, retina, etc. So we need to make sure we encourage our elderly population to get their eyes looked at. Same thing with the ears. As we get older, we can have changes in our ears of losing hearing loss. So there's conductive hearing loss, where we have impaired sound conduction, and sensorineural hearing loss, where there is impairment of the organ of the corti or its central connections. And usually this is more what we see with our presbycusis, it's called, where as we get older we lose our hearing. Meniere's disease is severe dizziness, vertigo, and tinnitus. They diagnosed my mother with Meniere's disease just recently because she had a dizzy episode and fell and was vomiting blood, all kinds of issues with hers. And so she's actually in therapy. They have physical therapy for Meniere's disease to see if they can help work on balance problems so that she's not constantly falling over. So it's kind of an interesting thing, but it is vertigo, and it's not your typical regular vertigo, but a severe form where you're dizzy. And so it's kind of interesting. Ear infections. We see ear infections with our little ones a lot. So otitis externa, where there could be an ear infection in the outer ear, or otitis media, where we have an ear infection within the ear. Most of the time with kids, when they have ear infections, we may not see the outer ear. It may not be externa. It might be internal. And so these kids are constantly pulling at their ears, probably, or I shouldn't say constantly, but pulling at their ear a lot. It's red, irritated. They may have a fever. So we need to monitor our little ones pretty closely. For us as adults, we can know we have pain in the ear and we go get it checked out. But it's just our little ones. It's hard to figure out what's wrong with them. But if you see them tugging at their ear, it's probably a red flag that they're having otitis media. So again, as we get older, we can have problems again with our hearing. We have a decrease in vascularity of our cochlea. Again, starts developing with presbycusis. As we get older, we can have problems with our cranial nerves 1 and 4 for our changes in our taste and smell. Sometimes with our smell, the olfactory nerves can cause things to be increased, so we smell things more, or it can decrease, and whereas we do not smell things at all very well, and hence smell has a lot to do with our taste. So if our smell has been decreased, our taste buds are probably decreased, and you see the elderly adding more salt to their diets because they don't smell it or they don't taste it. Speaking of taste, cranial nerves 7 and part of 9 are where we do our taste regarding sweet, sour, salty, and bitter. So again, they need to hyposmia is reduced ability to smell, and anosmia is no smell. So AN is always no without. And some patients can develop olfactory hallucinations. We see this in our schizophrenics, where they are smelling things and they smell unusual things, not typically nice stuff, but they could. But a lot of times those are things that it's a hallucination that it's not really there. Some patients can develop parosmia, which is they're not able to identify odors. So they can smell something, but they can't identify it. They smell a rose, and it's like, oh, I smell something sweet or something, but they can't really tell that it's a rose. So that's a disorder that sometimes we see. Hypogeusia is unable to taste things again, so then they are a reduced ability, and so that's where they salt a lot. Ageusia is a loss of taste function. And then some patients can develop what's called parageusia, where they have that metallic taste in their mouth, or bad taste. And so they can brush all they want, but it's still there. And so a lot of medications can cause this. So we need to teach our patients to eat with plastic silverware and things like that, so that the metallic taste doesn't increase with metal in the mouth. So like I said earlier, as we get older, things change. Most things decline. We have a lot of times a sensation of smell and taste that decrease. Touch decreases as well as we get older. Depends. We can also have proprioception, where we have problems in our own position of our body. It can be an inner ear problem, could be a visual problem, maybe just a balance problem with joints. But again, proprioception is when the patient is unable to position their body straight. Vestibular nystagmus is involuntary movement of the eye. We talked about that. Vertigo is dizziness. We talked about that. And Meniere's disease, we talked about that regarding vertigo and tinnitus. And I think that's pretty much in a nutshell. And I appreciate you listening to this lecture. Have a great day.